Okay, I am going to present a couple of slides to give you a sense of the kind of research that I want feedback on. And I've titled this Step Care Low Intensity Treatments for Stress Disorders. All of these are sort of words that may be sort of unfamiliar, so I'll explain them in more detail. The context really for my kind of work is a really big public health problem in the US, which is symptoms and disorders like depression and anxiety, which are also known as stress disorders. Sometimes they're known as internalizing disorders or distress disorders. I'm going to call them stress disorders because it's a little bit of a simpler term, but basically what I'm talking about is upsetting negative emotions that typically manifest themselves as depression and anxiety, but for some people it can be a little bit more like irritability, or sometimes some people feel their stress in a more physical way, like difficulty concentrating due to worry, but I'm basically referring to all of these as kind of stress disorder symptoms. A lot of people don't know this, but these kind of problems are leading causes of disability worldwide, but also in the US. So depression and anxiety really are leading causes of disability. We have effective treatments for depression and anxiety. So most people prefer to do psychotherapy. Most people are used to thinking about psychotherapy as like you do this kind of one-on-one therapy where you sit across from someone and they support you, they give you a little bit of education, they teach you skills, they help you think about your life in different ways. And there's been a lot of studies in which that kind of way of doing psychotherapy is effective for depression and anxiety. It's effective if you compare it to control conditions like not getting any treatment, but it's also effective if you compare it to stronger control conditions like, for example, care as usual, so access to whatever care is available in the community, and also if you compare it to medications. And in the short term, medications and one-on-one therapy tend to be roughly equally effective. Over the long term, psychotherapy does better than discontinuing medications. So it's really good that we have these effective interventions like psychotherapy or talk therapy, but one big problem that we have in the United States is that we don't have enough psychotherapists for everybody that will become depressed. Some of my colleagues try to think about, well, how can we train more therapists so that there will be enough therapists for everybody that will become depressed, but that is a very big undertaking. And where it stands right now, in general, it's just hard for anyone to get access to psychotherapy, but it is especially hard in places like where there aren't a lot of large metropolitan cities. So for example, we live in Indiana, and there are large rural areas in this state, and not a lot of specialty mental health providers, which means that if you find a psychologist, it can be somebody really good, but usually you'd have to wait a long time to get to see them. And during that time, your mental health could deteriorate. One of the reasons why I don't pursue research where it's like, how can we train more therapists, is that really not everybody who has depression or anxiety needs to go to a therapist once a week for 2, 3, 4, 5, 6 months. A lot of people can benefit from other types of intervention. So in my research laboratory studies something that I called low intensity interventions. By low intensity interventions, I mean that the interventions don't require as much time, energy, and money from the patient side of things, but also from the provider side of things. Usually, these are types of interventions that are focused on teaching you about mental health and teaching you coping skills to make your mental health better. I think a lot of people know these as, for example, apps, but you can also think about educational websites, you can think about books, you can think about videos that teach you coping skills so that you are sort of become your own therapist. I'll talk to you about two types of interventions that we study. One of them is single session interventions. Like their name imply, a single session intervention is basically you have one sitting where, for example, you read a website and you learn coping skills. The other kind of self-help interventions that we study usually require more than just one sitting. So for example, it could be a book that has multiple chapters. It could be an app that you're being told to go on it weekly. When we give self-help content like in books or apps, you can usually give it one or two ways. One way is just to tell the person to do it on their own. So to tell them, for example, like this book has 5 chapters, every week you should read a chapter, and basically rely on the person to do it on their own. Another way to do it is you give the person those same instructions, but you tell them, hey, here's a graduate student that has training in how to help you use the book. They're going to meet with you once a week for the next 5 weeks to make sure that you're reading, to provide you with some emotional support, to make sure that you're understanding, to make sure that the material is clear, that it makes sense to you. These kinds of low intensity interventions, we know they work. So I've done research to suggest they work. A lot of other people have done research in the United States and Europe and a bunch of other countries. These low intensity interventions are effective. One problem that we have in the current literature is that these single session interventions where you just sit and you just kind of, for example, do a website in 20, 30 minutes, it seems like they work really well for youth, for young people. So I think like children and adolescents really. It's not so clear how effective they are for adults. So people over 21, it's not clear how effective they are. When you think about the longer forms of self-help, we know that they are effective, but people have a really hard time completing them. So the guided self-help tends to be really effective in studies. They found that it's as effective as face-to-face therapy with a trained provider, but people are really likely to drop out. So something about doing it seems to be hard. So this unguided self-help, when you do it on your own, it doesn't have as good outcomes, but people are more likely to stay in the study and complete the unguided self-help. So in other words, it seems like having a coach is good, but for some people, it may be a barrier that may make them less likely to complete the study. Another problem is that these apps and these SSIs, they are effective, but a lot of people do them and they still need a little bit of help, right? They still need to see a one-on-one therapist. A big problem in the literature that we have is that I've been telling you, SSIs work, guided self-help works, but it's unclear for whom they work, right? So we know that not everybody benefits, but we don't have a sense, for example, is it true that older people don't do as well with the single sessions, but youth do? Are there, for example, gender differences in who benefits from it? So my lab studies a lot of these questions, in particular because not everybody is going to benefit from the single session or self-help. I want to take this approach where we give people the chance to get more treatment, right? To do one treatment, and if that doesn't work, try another, and if that doesn't work, try another, which is what I've been calling step care, right? Which means like you keep getting more intervention. So just to give you an example, over the past year, we recruited almost 300 people across the state of Indiana, and we included them in the study if they had at least mild levels of stress on a symptom questionnaire that we give them that's been validated in other research, and if they weren't very actively suicidal. We gave everybody access to the single session intervention. So the single session, again, it's that digital thing that you only do once that teaches you skills. And the reason we gave everybody access to it is because, we want people when they're participating in our studies to have help as quickly as we can give it to them. After that week where people have done the single session intervention, we randomized them. Everybody got a self-help book. They could also get the book digitally, but half of the people got the book and completed it on their own, unguided or self-guided, and the other half received guidance. So the guidance here was we train graduate and undergraduate students so that they meet with people anywhere from 3 to 6 times a week and kind of help them learn how to use the book. Sometimes it's just so somebody can help you be accountable, right? So you can say, hey, I didn't do the book. Can you help me figure out what may make it more likely for me to do the book? And then after that, we ask people, so we basically give these 2 stages. In stage 1, you can do the SSI if you choose. In stage 2, you can do this self-help, either guided or unguided. And we don't already have a stage 3, but we ask people, hey, if we offered you the chance to do psychotherapy or talk therapy over telehealth, would you be willing to do it? And so we did that over the past year, and we wrote a paper about it. It's currently being reviewed by journals. A couple of the things that we found, one is that it's primarily women that are interested in the study. So we recruit on social media, and mostly we get women. When we give everybody the chance to access the single session intervention, that thing that you do in one sitting, it seems like only 40% of people do it, so not everybody does it. And the people who do it don't seem to do any better than the people who don't do it. They do tend to stay in the study. They're more likely to stay in the study. So it's possible that something about having that like immediate contact with material that's helpful makes you more likely to stay on board for the rest of the study. In stage 2, when we give people guidance, it produces better outcomes than no guidance, but people drop out more if they have the guidance. And almost everybody was interested in doing telehealth after the end of the study, even though everybody had improved. So I'm currently planning another study where we want to recruit a very large sample of people across the state of Indiana. And basically, at step one, randomize them to either doing a single session intervention or not doing the single session intervention. The reason we are randomizing as opposed to giving everybody access to the single session intervention is because when we don't randomize, we don't know whether the differences between conditions are because literally the conditions are different, or because there's something about being the type of person that does the single session that makes it so that you have different outcomes. So for example, it could be that people that are really depressed are very likely to do the single session intervention, and they don't, they're more depressed than the people who don't, so it looks like they don't improve, but maybe they really would have, right? Or it could be that people that are really feeling unsupported in their regular lives are going to do the SSI, but and that lack of support explains why they get worse, whereas the people who don't do it don't. And so we use randomization really to know whether the treatment causes changes in outcomes or changes in engagement, whether people drop out the study. At the step two, we would do a randomization kind of like in the other study where you get this guided low intensity type of treatment. The treatment is called CBT, by the way. Or you do it unguided. The thing that will be different in this study is that after this step two, you'd be randomized to either get CBT with a therapist that does telehealth, roughly 12 sessions, or if you don't get that treatment, right now I'm thinking you get guided self-help. And for some people, if you already got guided, that just means you get an additional 6 weeks to get better. If you had previously didn't have a coach in the unguided condition, now you get the coach, right? So you get the opportunity to talk to this person that I trained so that they can help you use the guide effectively. So a couple of questions that the study will be able to answer is basically like, what is the best sequence of treatment? We know that this intervention, this way of doing interventions, is cheaper, it's faster, it's more scalable than giving everybody therapy, but we don't know what the best way of doing it is, right? So the study could help us identify that. It could also help us think about like, who are the people that in step 1 and 2, they're not going to get better, but they would get better if they were given access to therapy more immediately. The study could also help us identify who doesn't get better with any of these treatments, and for example, may need medication, right? So we're planning a large study so that we can answer these questions. And of course, it would have implications. For example, if you are a therapist, you could think about using these tools in your practice so that if you can't see somebody for, I don't know, 8 weeks, but we already know that they're the kind of person who would do well with this guided intervention, you could suggest to them, hey, while you are waiting, you could do this treatment before we start therapy and it could help you. A couple of questions I have for you as somebody that's hearing about this are basically, does this make sense, right? Like, are we offering something that if you are a person that needs treatment for depression and anxiety, makes sense to you, right? Does this research answer a question that you care about, right? So I care about people getting treatment for depression. I care about giving people access to tools so they don't have to wait for a therapist if there's not a therapist, but is it something that you care about, right? Is it something that seems important to you? It's just one study, but the study has 3 randomizations, right? In the first week, you could get the SSI or not. In the second week, everybody gets a self-help material, but some people get a guide and some people do it purely self-guided or guided. And in the third step, you get teletherapy versus guided self-help. So also, I want to ask the question, is this something are each of these things that make sense to you? I also have a specific question about that stage 3. Right now, I'm designing a study so that you either get teletherapy, so that would be like traditional therapy, but doing it over telehealth instead of in person, versus guided self-help. But some people in the study will have already received guidance, right? So does it make sense to say to those people like, hey, you're going to get 6 more weeks of the guidance, and for some of them, it wouldn't have helped them that much, right? Or does it make sense to offer people a new treatment program? Say, okay, you're going to get guided self-help, but it'll be a different self-help manual. Or does it maybe make sense to say, well, let's not give people treatment right now and offer them something else? So these are the kinds of questions that I'm hoping to answer, but really any feedback on the project and how it's received by people in the community would be helpful to me.